Hello, everyone. Welcome to the Relationship Between Inflammation, Arthritis, and Nutrition webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD, ourselves, and Pain BC in collaboration with the Canadian Pain Coalition. It's made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to our organization. And as mentioned, my name is Tanya. I'll be moderating the webinar and handling the question and answer session today. And our presenter is Dr. Kristen Baker. Dr. Baker is an assistant research professor at Boston University College of Health and Rehabilitation Sciences in the Department of Physical Therapy and Athletic Training. Dr. Baker's research has primarily focused on examining the role exercise and nutrition play in the development and progression of knee osteoarthritis, both structurally and clinically. She has developed and tested a strengthening protocol for knee osteoarthritis and examined the role of dietary fatty acids in inflammation in osteoarthritis. In her most recent clinical trials, she extended the strengthening protocol to include behavioral medicine and technology to examine the effect of these approaches on the adoption of and adherence to exercise in adults with knee osteoarthritis. All right, I'll hand it over to you now, Kristen.
Great, thank you, Tanya. Welcome, everybody, and thank you for joining us today for this talk on inflammation, arthritis, and nutrition. So there is a picture of me. I always think it's nice when somebody's giving a presentation to be able to put a face to the voice, and a brief little bio which Tanya so nicely just went through. So we won't, I won't go over that again. So let me just start with an overview of what I wanted to talk about today. First, we're going to talk about what is inflammation. I want to make sure that everybody has a clear understanding, although I'm not an immunologist or an expert in this, but to really understand the different processes and how it plays a role in arthritis, and then also how potentially nutrients could impact the processes of inflammation. So via talking about inflammation, we will talk about the general concept, acute versus chronic, the innate versus the adaptive immune system, and then inflammation and disease, and then more specifically about how that inflammation is carried out specifically in arthritis, specifically again in osteoarthritis and in rheumatoid arthritis. Most of my research, as Tanya said at the beginning, has really been in osteoarthritis. However, there's a lot of similarities, especially in the joint-specific inflammation that occurs in rheumatoid arthritis and osteoarthritis. Then second, we're going to go into how can nutrition impact inflammation. And I'm going to talk about the nutrients, or how nutrition specifically by groups of nutrients. So I'll talk a little bit about macronutrients, specifically carbohydrate and fats, and then micronutrients, largely antioxidants, and the impact that they may have on inflammation, and then some specific dietary patterns that have been studied looking at the effects that they have on inflammation. So let's start with inflammation. Now this is from the Latin word inflammo, which means I set alight or I ignite. And it's fundamentally a protective response. So without inflammation, there would be death. We would not be able to sustain life if we did not have inflammation. So wounds would never heal, and infections would go unchecked. So I want to talk about chronic versus acute inflammation to start out with. And you see across the top of this slide that we have the host, environment, and the stimulus. So these are various triggers or factors that can affect the immune response. So for example, just age or somebody's genetics can affect their immune response, and just how their immune status is. Lifestyle choices, exercise, nutrition, which we're highlighting today, exposure to toxins, air pollution, and various other toxins, pesticides. are other things that can affect the inflammation process. And then, of course, stimulus. So you could have an injury, a cut, a trauma injury, a broken bone, or you could have an infection, a virus or a bacterial infection. So let's move down now and talk a little bit about acute inflammation. So acute inflammation is inflammation that will last. When I say acute, I mean something that could last minutes for something like a paper cut to maybe begin healing, or it could potentially last for days. So say you got a flu virus or an infection of some sort, and it took you a week or several days to get over a cold, or a week or more to get over the flu virus. So it's an injury or an infection. Whereas chronic infection is something that occurs for weeks, months, years even, is largely due to some of these environmental triggers or the host, genetics or age, poor nutrition, stress, and aging. Acute system fails to actually arrest and stop the infection or the wound, and cells become damaged, it becomes clinical symptoms, and there's basically a failure to maintain a healthy homeostatic state when you end up with chronic inflammation. So going back to this acute response, this is sort of the typical response that we think of when we think of inflammation. So you have a tissue injury caused by some sort of a physical trauma or a chemical agent or a pathogenic microorganism, some of the things I spoke of earlier, the triggers. You get the capillaries widening, and you get increased blood flow. Then you get increased capillary permeability, and you can get release of fluid into the tissues, attraction of white blood cells to the area, and migration of these white blood cells to where the injury has occurred. Now, if this is a viral or a systemic infection, bacterial infection, then you'll get more of a systemic response, and you'll get more proliferation of these white blood cells, and also fever. So you get some of the clinical signs of inflammation would be heat, redness, tenderness, swelling, and pain. And I think we're all very familiar with this type of an inflammatory response. So with that said, let's move. We now know a little bit about the difference between chronic and acute inflammation. Let's move farther down this chart to innate versus adaptive immunity. Now, what I mean by this is when you talk about innate immunity, this is the immune response that or the immunity that you're born with. It tends to be a localized response. It's your first line of defense. And it's largely, in a minute, I'm going to show you a slide of the different types of cells that are involved in these two, in the innate versus the adaptive immune response. So largely, when the innate immunity is overtaxed and it can't take care of the infection or the trauma, it will call on the adaptive immunity, which could take several days to actually kick in. This is a much more highly specialized response, and I'm also going to show you the different types of cells that play a role in the adaptive immunity. And they actually go out and destroy whatever the pathogen that has taken over the body is. And what you can see, so when you follow this chart down, you can see the three boxes down on the bottom, whereas if you have a deficient innate response, so the immune signaling is deficient, you're not going to be able to capture and rid yourself of that infection. If you have an adequate response of the innate and the adaptive, which may work together, or it could be just the innate immune system when the infection is halted, you'll have a recovery and protection from reinfection. Now, we talked a little bit about chronic inflammation, and so you can have excessive innate immune signaling, which can lead to chronic inflammation, which I talked about earlier. And this is something that happens in disease. So with the innate and the adaptive immune system, they work together. They signal across and talk to each other and work together. However, when you have that immediate rapid response, the cells tend to be largely macrophages. The macrophages, then you will then get some cytokines and some other sort of pro-inflammatory molecules. You can see some of the white blood cells here and the macrophages, and you can get natural killer cells. Whereas the adaptive immunity is much more specialized, as I said, and you get B cells and T cells from which have a very specific response to foreign bodies and produce antibodies and actually have a stored memory of, or memory cells of the invading pathogen that they can call upon at a later date if they're invaded by that pathogen again. So although they work together, there are very different cells in play in both of these different responses, the innate and the adaptive immune system. So I want to talk a little bit more about chronic inflammation. So we see a lot about inflammation in the news. We hear a lot about how it's bad and how it's related to so many diseases. What happens, again, I just want to remind you, we have the innate and the adaptive immunity that work together, but in chronic inflammation, you have these immune cells that you get this repetitive cycle and an ongoing stimulus. So something fails to arrest the cycle of the immune cells. Now moving on from the chronic inflammation, you get this repetitive cycle that, now one of the things that's interesting about this is it really is still largely unknown why this occurs. We're still trying to get a handle on, in the research, why the stimulus is a repeated cycle and goes on and on. But what we do know, and what we're getting a lot of information on now, is how it's related to many, many different diseases. There's this underlying chronic inflammation process. And what I wanted to point out here is that infection injury, which we just talked about, stimulates that inflammatory response. And you hope you get a healing process. But if the healing process does not arrest, you get this continued cycle, you can end up with chronic inflammation. We also are learning that obesity and diabetes also seem to drive some chronic inflammation. Now, then we have all these other diseases where the black arrows are pointing out. And the difference here is that a chronic inflammatory process can end up causing many of these types of diseases, So the metabolic syndrome, arthritis, which we're going to talk more specifically about today, Alzheimer's disease, asthma, allergies, many of the chronic diseases, ulcerative colitis, inflammatory bowel disease, eye disorders, cardiovascular disease, all these have an underlying chronic inflammatory process that's occurring. So moving on, let's talk specifically about how inflammation, the inflammatory process is at play in arthritis. I wanted to start with osteoarthritis. Now, largely what happens in osteoarthritis is you get a malfunction in the innate immune response. So there is not the halting of that immune process, and it continues to go. So it's largely something that's happening locally. It's not a systemic response. This also is occurring in rheumatoid arthritis, but I'll talk in a minute about other things that also are happening in rheumatoid arthritis. So you can see in this particular figure, we have a knee joint. And in the knee joint, we have the two bones that are come together to form that knee joint, and we have the cartilage on the surface. And we have the synovial fluid, or the synovial lining, on the outside of this joint. Now, what happens in chronic inflammation is you can get a lot of angiogenesis and neurovasculation in that synovial lining, so you get leakage. You get an inflammatory-induced vascular leak, and you get the production of many inflammatory molecules, plasma proteins, complement, adipokines, and cytokines. You can also get some from the fat pad as well. And then as the synovium and the chondrocytes, which is this, you have the synovial layer and then you have the chondrocytes, which are the cells of the cartilage, you can get inflammatory mediators from these as well. Now, what causes all this in osteoarthritis is that you can have an overuse injury, obesity, which is a lot of stress on the joint. You can have altered biomechanics. So you can almost think of it as like an injury or traumatic injury, but it's occurring very slowly over a long period of time when you think of overuse or altered biomechanics. This can set up the process, just like an injury, of inflammation, and the knee joint sees it as an injury and is trying to heal it. But somehow, and like I said, we still don't understand why this process does not get shut off and continually occurs and turns into a chronic inflammation and tissue damage and remodeling of the joint. So this is what happens when you have osteoarthritis. It's very localized, though. There's not a systemic response. It happens in the joint this is occurring. All right, so we talked about immunity going askew in osteoarthritis. I want to talk a little bit about rheumatoid arthritis now, because what happens in rheumatoid arthritis that's different from osteoarthritis is you get this very robust chronic inflammation, also in the adaptive immune response as well, which is something you don't see in osteoarthritis. Or at least the research or the literature up to this point has not shown that. It's largely the innate immune response. So in rheumatoid arthritis, you have this very robust or chronic inflammation occurring in the innate immunity, but you also have it in the adaptive immune response, so those more specialized cells. And then you get a destruction in the joint, but also there is a systemic, because of this adaptive immunity robust response, you get a systemic chronic inflammation as well in rheumatoid arthritis. Besides just having joint damage in rheumatoid arthritis, you can get other clinical symptoms of a systemic infection, so fever and fatigue are other clinical signs or symptoms of rheumatoid arthritis that happen largely because you get this robust chronic inflammation in the adaptive immune response as well in rheumatoid arthritis. All right, so moving on, I wanted to say, now that's just a very brief overview of the different aspects of the immune system and how they may be working in chronic inflammation and also more specifically in arthritis. Now I just want to go a little bit into an overview of how nutrition can impact inflammation. So we talked originally about I just want to go back up to here where we showed that our environment, our exposure can have a large effect, and this is diet or nutrition is one way that can filter down and affect the chronic and the acute inflammation. Where nutrition can play a role is probably largely in the signaling that occurs between the innate and the adaptive immunity, and also in the reactive oxygen species that then are produced in this chronic inflammation that starts to occur, the robust adaptive immune response. You get lots of reactive oxygen species being produced there too. So that's largely where a lot of the nutrients will have their effect. And you can see I circled both of those areas in this depiction of the immune response. And we will talk briefly as we go through some of the nutrients about the specific cells or areas that some of these nutrients may be impacting. All right, so let's start with the macronutrients. So I want to start with excess calories, and then I'm going to go into carbohydrate, and I'm going to talk a little bit about the glycemic index and sugar intake and how these impact inflammation. And then we're going to move into fats, briefly talk about trans and saturated fats, and then the omega-6 and omega-3 fats and how they may impact. I'm also going to mention some studies that have been done on olive oil, so the monounsaturated or omega-9 fats as well. So what do we know about excess calories? We know in the Large Calorie Restriction Society study that about a 30% reduction, about 1,800 kilocalories a day, increases the serum levels of pro-inflammatory factors. It also decreases body fat and can improve many of the other parameters, BMI, glucose tolerance, insulin sensitivity, and lipoprotein. Tanya, are you still there?
Yes.
Okay, sorry about that. The thing just keeps popping up and down, so I'm not too sure. So one way, just by calorie restriction, we can control some of the chronic inflammation that goes on. We know that. Now let's talk about carbohydrates in the diet. High glycemic, the GI is a glycemic index diet. So diets that are really rich in refined carbohydrates, we know there's been several studies that have shown will stimulate pro-inflammatory production. So this is a lot of those molecules, those cytokines that communicate between the innate and the adaptive immune response that get upregulated with a high glycemic index diet. So now I want to talk a little bit about added sugar. There's been a lot of media attention put on sugar over probably the last few years, especially since the American Heart Association came out with some recommendations, which are they're the only institute in come out with a sugar recommendation. And there's been numerous studies that have shown the effects of a high sugar intake on inflammation. So I just wanted to point out to here that the average American consumes about 22 teaspoons of sugar every day. This is about 18 times more sugar than we used to consume, say, 50 plus years ago. The American Heart Association has made recommendations, and this is based on what, one, helps decrease inflammation, and also is based on prevention of dental cavities and various other things, but also based on some of the studies, especially looking at heart disease, where inflammation is related to heart disease. So in this recommendation, they're saying that 9 teaspoons for men and 6 teaspoons for women. So you can see this is a drastic difference in what the average American is consuming now. So this can make a large impact on the inflammatory process just by decreasing our glycemic index and our sugar intake, which are sort of one and the same, because the higher the glycemic index, the quicker that food is going to break down into simple sugars. Now, I also want to point out that this recommendation is based on added sugar, so this doesn't include the naturally occurring sugars that are in milk and that also are in fruit. So these are added sugars. So if you drink a soda, for example, or if you add sugar to your tea or coffee, that's added sugar. Or it's really processed food. So if you buy a packaged food and there's added sugar, so like cereals and cookies and things like that will have a lot of added sugar in it. All right, then I want to talk a little bit about the more beneficial side of complex carbohydrates. So this would be whole grains, beans and legumes, and a low glycemic index high fiber diet for one year. In this study, significantly lowered plasma levels of C-reactive protein, which is a marker for inflammation produced in the liver. And this was in a randomized trial of people with type 2 diabetes. Okay, so we talked about the complex. Let's move on. I apologize for the lack of flow here with the technical difficulties. But let's talk a little bit about trans fatty acids. I think the fatty acids are one of the most interesting when it comes to talking about inflammation. You are what you eat, and so largely what types of nutrients we take into our body, especially fats, because the outer layer of all our cells are made up of fats. And so the types of fats, this is where we're going to talk about trans fats, saturated fats, the unsaturated fats, omega-6, omega-3. What we take into our diet will largely distinguish what that cell is made up of. And then we'll distinguish what that cell is, the function of that particular cell, or what its signaling capabilities, as well as what it produces. So let's start with the trans fat. We've heard recently also about how terrible trans fat are, and they also are associated with inflammation. So these can get incorporated into your cell membranes, and they actually get incorporated quite well into the cell membranes at twice the rate of non-trans fatty acids. And what this seems to do is clump cells together and binds to the arterial walls, and that is like an injury that the arterial wall sees, and you get this release of pro-inflammatory cytokines. And in chronic heart failure, it has also been shown that the trans fatty acid level of the red blood cell membranes, there's an association between the amount of that in the red blood cell membranes and plasma biomarkers of inflammation. So that's a little bit about trans fat. Now, what about saturated fat? Saturated fat largely comes from dairy products, cheese, milk, yogurt if you eat full-fat yogurt, meats, and pro-inflammatory markers in mice with a diet that's comparable. There's an increase, in pro-inflammatory markers. This is a mouse study with a diet comparable to the level in the average American diet, which is about 12%. of saturated fatty acid. So we also are getting some information that saturated fat at certain levels can also increase inflammation in the body as well. So also what I wanted to mention is largely what we get from, especially from meats, and some of the saturated fatty acid sources is the fatty acid arachidonic acid. And one of the reasons this can be inflammatory is because the way this arachidonic acid is processed, it largely produces inflammatory cytokines or pro-inflammatory immune cells. And you can see that depicted in this particular diagram. You get the cyclooxygenases, which and the lipooxygenases, which come down to make these prostaglandins or inflammatory cytokines, thromboxans and leukotrienes. And you can see here that largely they are inflammatory. So the more arachidonic acid you have, there have been studies that are showing the more production of these inflammatory cytokines you see in the body. So we talked about trans and we talked about saturated not being very potential for inflammation or being more harmful and upregulating inflammation. Let's talk about the omega-3s and the omega-6s. So we hear a lot about omega-3 being beneficial and omega-6 more neutral or potentially pro-inflammatory. So first let me point out that omega-3 is the alpha from vegetable sources is largely the alpha-linolenic acid, and you will get this from things like chia, flax seeds, walnuts, canola oil has some alpha-linolenic acid, omega-3 in it. And then the difference between the fish oils, they are also omega-3, but they're a longer chain fatty acid, and those are the EPA, DHA, or eicosapentaenoic or docosahexaenoic, and these come from the fatty fish. The sardines, the mackerel, the salmon, whereas the omega-6 fatty acids, linoleic acid, largely comes from the oils, safflower, corn, soybean, and sunflower. You will find that many of these oils are particularly high in processed foods. And one thing that I wanted to point out here is that we used to historically have a ratio about 1 to 2, so 1 part omega-3 to 2 parts omega-6 in the diet. The current ratio is more like 1 to 12, and this is largely due to the increase in a lot of these types of oils found in processed foods, the omega-6s, the soybean, the corn, the safflower oil, and decreasing the intake of the more whole foods or the fatty fishes over time. Now, why is this important? Well, this is important. This particular slide depicts the pathway of metabolism of the omega-6 and the omega-3 fatty acids. And you can see here you have the linoleic, the omega-6 pathway, and the alpha-linoleic omega-3 pathway going down to the longer chain fatty acids. And in the omega-6 pathway, it leads down to arachidonic acid. Of course, you can have meat and dairy entering directly in to the arachidonic acid, whereas the oils will make their way down. And you can see that these are largely the more pro-inflammatory that comes down this pathway, cytokines that are produced. Over on the omega-3 pathway, so the vegetable sources, which I talked about some of the seeds, flax seeds, chia seeds, walnuts, dark green leafy vegetables as well, can be metabolized down to some of the longer chain fatty acids to a certain degree, but there's not a huge conversion that takes place in these shorter chain vegetable sources down to the longer chain. But the more positive thing about the omega-3 pathway is that it produces more anti-inflammatory immune molecules or prostaglandins than does the omega-6 pathway. I also wanted to point out here that you have these enzymes which are responsible, the cyclooxygenases, for these conversions of the fatty acids down into these different prostaglandin series or inflammatory molecules. And along up you also have other enzymes that make the conversion, and there's other nutrients which I'm not going to emphasize a lot today, but that are very important in as cofactors in these various enzymatic reactions. So things like magnesium and some of the B vitamins and zinc and some of the antioxidants are very important in order for these enzymes to work optimally and at their best. That's one of the ways that omega-3 fatty acids can be potentially beneficial in controlling some of the inflammation. And also I wanted to go back and just mention when I talked about the ratio, so historically it was more 1 part omega-3 to 2 parts omega-6, and it's more like 12 to 1 today. One of the other reasons this is so important is that these fatty acids compete for these enzymes to be metabolized down to these inflammatory molecules. So therefore, if you're getting an abundance coming into the omega-6 pathway and very little coming into the omega-3 pathway, it's not going to give even the little that has the chance, the little that's coming in the omega-3 pathway, a chance to metabolize down more anti-inflammatories. It's being overwhelmed by the omega-6 pathway. So that's another reason the ratio is very important too. And there have been studies that have looked at the ratio, so not only just supplementing or increasing the diet with omega-3, but also decreasing at the same time with omega-6 fatty acids, so that you don't get these enzymatic reactions being overwhelmed by the omega-6s. And that can be very important, probably some of the more modest effects in some of the studies on the fatty acids, especially the omega-3, is that if you don't control the underlying dietary intake, you may make little impact by supplementing with higher levels of omega-3 if you still have very high levels of omega-6 fatty acids in the diet. All right, and then I just wanted to briefly mention olive oil, or the monounsaturated fatty acids. And what I wanted to mention here is there was recently, and I put that citation down here, studies that have come out looking at olive oil and the effects specifically on inflammation. And where olive oil is working is directly, one of the ways anyway, is directly on this pathway of the cyclooxygenases converting these fatty acids into the inflammatory, pro-inflammatory, and anti-inflammatory molecules. So this is how the anti-inflammatory medications work. Or ibuprofen will block these cyclooxygenases. It will block both the COX-1 and the COX-2. So it will block some of the anti-inflammatory effects of the cyclooxygenase 1, but it will also block the pro-inflammatory of the cyclooxygenase 2 molecules. So there's a substance called olecanthal, which is in olive oil, especially in the virgin olive oil, cold-pressed virgin olive oil. It has the highest levels of it. It is very similar to what we know as ibuprofen or the anti-inflammatory molecules, and will directly inhibit this pathway. All right, so moving on from fatty acids, I just want to get through a few more of the nutrients so we can open up for some questions. Tanya, you're still there, right?
Yep, still here and can hear you great.
Okay, good. So what I want to talk about next is some of the antioxidant nutrients. And the three that we probably have the most sufficient data on at this point is vitamin C. There's been some studies in vitamin E, and also in the polyphenols. So vitamin C and vitamin E can largely act to decrease the oxidative stress that is happening when you get this chronic inflammation. And the polyphenols have also been shown to be a highly potent anti-inflammatory molecule. And these could be broken down in, there's hundreds and hundreds of polyphenols. The two categories, two such groups that are most largely that you'll hear about is the flavonoids and the lignans. However, we still need to get much more research done on this because we don't have good measures of the tissue levels of these, and the tissue concentrations in many of the studies. So this is still fairly preliminary, looking at some of these polyphenols, but we do have some evidence, or we do have very good evidence that they are very potent antioxidants. And last, I just want to say a little bit about dietary patterns that have been studied. There's been some studies done on the Mediterranean diet, which gets back and touches largely on all the components that I already talked about. That tends to be a high fiber diet. It tends to have a lot of the olive oil in it. It tends to have a lot of fish, some of the fatty fishes that contain a lot of the omega-3 fatty acids in it, and is a low glycemic index diet. So there have been studies that have shown that these decrease they have anti-inflammatory effects and decrease a lot of the inflammatory molecules in the blood. Also, there have been studies done on diets high in fruits and vegetables. They also have been shown to decrease a lot of the inflammatory molecules, largely due probably to the combination of the vitamins, minerals, fiber, and polyphenols that are provided from a diet that's high in fruits and vegetables. All right, so let's just see if we could wrap up on this sort of discombobulated presentation and just see what some of the key points were. So we just briefly tried to understand about the inflammatory process. And we talked at first about regulated inflammation, that it's an essential response for infection and injury, and it restores homeostasis in the body. Without it, we couldn't survive. But then we have chronic or unregulated inflammation. And many things happen in this chronic and unregulated inflammation. One is just the loss of the barrier function. So I talked a little bit about that when we talked about osteoarthritis, and you get this leakage in the synovium, the lining of the joint. So depending on the tissue, you can get the loss of barrier function in the specific tissue. You get a response to what normally would be seen as benign substance. So like in the osteoarthritic joint, we're showing some of the cartilage molecules that might break off from trauma or from degradation that's happening due to altered biomechanics and chronic trauma to the joint. And you get a response that you would not normally get to a benign substance. And then you get increased production of these inflammatory cells in places that you wouldn't normally find this increased production. Now, why this is all happening, as I mentioned, we still don't have a good handle on. But the more that we learn about this, the more avenues we're going to have to be able to impact it and create treatment to be able to stop chronic inflammation, which is so important because I showed you how many diseases are related, have an underlying chronic inflammatory process to it. Then we moved on to nutrition, and how can nutrition impact inflammation? Well, it certainly can reinforce a lot of the regulatory pathways controlling inflammatory responses. So I pointed out two main areas, that communication, the production of cytokines that communicates between the innate immune system and the adaptive immune system. Nutrition seems to, a lot of the preliminary evidence, seems to be able to impact the production of those pro-inflammatory molecules and down-regulate them. It also can shift the cycle of oxidation that occurs when you get this robust adaptive immune response. So it now one of the ways that nutrition, it can also contribute to just giving a more robust homeostatic control. So it gives you more avenues to control whatever the triggers are that you're being exposed to. So the better nutrition and the more of these antioxidants and the more of the good fatty acids you have and the less sugar you have, the more you will be able to gain control over the stimulants, whether that be environmental, whether it be stress, whether it be lack of sleep, whether it will be a disease that has gone array and ultimately cause chronic inflammation. Nutrition can contribute to giving you more robustness to your response and gaining homeostatic control. So in a sense, it can widen the boundaries and help you deal with, widen the boundaries within which the inflammatory responses can deal with challenges. So, and also the potential dietary components that we talked about was the type of carbohydrates So we talked about low glycemic, higher glycemic, sugar. We talked about fatty acid intake, the harmful effects of trans fatty acid, potentially saturated fatty acid, and the potential benefits of omega-3 fatty acids. And then we talked about antioxidants, largely from fruits and vegetables. What we know, I gave you a lot of citations on those various slides that I showed you, is we have a lot of preliminary suggestive data. A lot of the studies are in vitro and animal studies. We have some clinical randomized controlled human trials, but not a lot of robust data yet. But we have a lot of very suggestive preliminary data. So really what we need to do is we need more good quality studies assessing the impact of nutrition on these specific nutrients on chronic inflammatory responses. Especially as we start to learn more about why this chronic inflammation is occurring and what are the parameters that are controlling of it, then we can link some nutritional studies to that as well. But we certainly need to get some more robust human studies in the literature about some of these nutrients that could help control the chronic inflammatory response.
All right. Thank you very much, Kristen. Let's see. We can just dive right into some questions here. There was a question around, you talked about omega oils, and someone was wondering if there's been any research done on coconut oil in terms of inflammation.
That is a very good question. I have not researched coconut oil. I'm sure that there has been some studies done on coconut oil, but I can't speak specifically to what those are. But it's certainly, you will see in a lot of the media touting coconut oil being a beneficial oil. I would say there's probably not a lot of good evidence to that yet, but that doesn't mean it isn't a good oil. I just don't think we have a lot of good literature or scientific evidence on that yet.
All right, and then someone was wondering, would mussels and oysters count as anti-inflammatory foods?
As anti-inflammatory foods in the sense of the oils that they're producing?
I think so, yes.
That they provide? Yes, certainly. They're not particularly super high in omega-3, but yes, they definitely provide some of the sources of those oils. So seafood will give you the more fatty fishes are the ones that are going to give you the larger sources of the omega-3 fatty acids. And those would be the mackerel, the sardines, the salmon, those types of fish, the deep cold water fish.
Okay. And then there was someone who was asking about supporting patients who are vegetarian or vegan. I know you talked about vegetables having the high antioxidants, but are there other strategies that you're aware of? Other sources, since they can't do the fish if they're vegan?
If they're vegan, yeah, that's a good. So I talked about the pathway that leads down to those more anti-inflammatory pathways, including some of the vegetable sources of the omega-3s. So if you are vegan, you certainly get a much higher dose of those types of things if you're eating a lot of green leafy vegetables, the deep green, chars and kales, collard greens, those types of things, as well as the seeds and the nuts. So walnuts, chia seeds, flax seeds, flax oil. You can add flax oil to salad dressings. You don't want to cook with it. You never want to cook with a highly unsaturated fatty acid. I think we want to. Most people will know that you want to cook with things that are more monosaturated or saturated fatty acids if you're doing high heat, and that's largely due to the damage that you'll get to the more unsaturated long-chain fatty acids at high heat. But flaxseed oil is another thing that you can incorporate into a vegan diet too. So there's a lot of ways that you still can get omega-3 and you can drive that pro-inflammatory. I think you want to be, being vegan, be careful that you balance the omega-6 to the omega-3 so that you don't get overwhelmed by the omega-6s.
All right. And then someone was asking when you were talking about the olive oil, if there was any information around dosage per day type of or requirements or anything like that that's known as far as how much for blocking the COX-1 and the COX-2?
There actually is, and don't quote me on this. I will answer this offline later because I will look up to be sure. But it's about 2.5, I want to say, tablespoons is equal to the dose, a dose of ibuprofen. And I have to look that up to be clear about it. But there has been a recommendation. I know that they came out in that particular study of what the amount of olive oil in a cold-pressed extra virgin olive oil that would give you the same effect as a dose of an average dose of ibuprofen. So I know that that has been
Very good.
recommended, and I can provide that to people after.
Okay, that would be great. And then we had someone asking about nutrition. You talked about rheumatoid and arthritis, but someone was asking about oh my goodness.
Psoriatic arthritis, yeah. So I highlighted osteoarthritis and rheumatoid arthritis because they're probably the largest populations. However, psoriatic arthritis, when I try to give sort of a broad overview of the inflammation, and really it's the same process that's taking place. It's just different tissues are being affected. So in psoriatic arthritis, it's different tissues. You still can have joint involvement, but you have more of a skin involvement as well, and you get that psoriasis. It still is systemic, but it's that same inflammatory, chronic inflammatory process. It's just the tissue that it's occurring in or where it's gone array is different. Does that make sense?
Yeah, I think so.
Yeah. Yeah. So it's very similar, and the same information would apply. It's just the tissues are different that it's affecting, but it's the same chronic inflammatory process.
Okay, very good. And then someone was asking about when people are prescribed anti-inflammatory medications, if you can speak to what types of inflammation they're trying to control and how it allows for healing.
Yeah, so that's a great question because I want to come at it from two aspects. One is, which I didn't mention up at the beginning when I was talking about inflammation is good. We need to remember that because a lot of times whenever somebody has an injury and they get that typical response that we know where you get the increased permeability, you get the swelling, you get the redness, the heat, those types of things that occur, we think that's bad in the sense that we want to dampen it. We get a fever with an infection, we want to take ibuprofen because that fever doesn't make us feel well. But we have to remember, or if we injure ourselves, we want to take ibuprofen to control the swelling or the inflammation that goes there. But the first and foremost thing to remember is that inflammation is occurring to heal. That is its primary purpose. So we want to be careful that we don't dampen the healing process, but when you end up into a more chronic inflammatory process, that's when you want to bring in the medications to help dampen the inflammation. And where it will do that is down, so like the ibuprofens will dampen the production of the inflammatory cytokines. So in that pathway where I talked about the cyclooxygenases, I'm going to go here to give you a visual. Down to the, sorry here, bear with me if I can get down to the, yeah, so when we get down, for example, here, the cyclooxygenases, but they're responsible in both pathways, omega-6 and omega-3 or arachidonic acid, these so our ibuprofens and our Advils will block this pathway. That's also what I said, olive oil has a component of it that does the same thing. So they're diminishing the production of these particular molecules. And you can see some of them are anti-inflammatory and some of them are pro-inflammatory. But the point is to block these pro-inflammatory, but it will block both pathways. The cyclooxygenase, so that's the primary of where the medications come in. We also have COX-2 inhibitors, which specifically only block the COX-2 enzymes, which really are responsible for mainly the inflammatory cytokines. And those are like the Celebrex and those prescription anti-inflammatories, and they are specific to the cyclooxygenase 2 largely, and will block predominantly the pro-inflammatory prostaglandins or molecules.
All right. We had someone with a question around how supportive is it to do a supplement versus the actual food, particularly with relation to omega-3 fatty acids?
So the question is whether you should use a supplement or food, or what's the difference between use supplement or food?
I think more what's the difference.
Okay, so that's a good question because a lot of the studies have been done using supplements. There has been a study increasing the consumption of fish that is so, in specifically rheumatoid arthritis, that has shown a beneficial effect in dampening the inflammatory process or decreasing the pro-inflammatory molecules. So the difference, it really is that it's hard to get enough of the omega-3 in your diet at the level that has shown to decrease the inflammatory molecules. So in that case, taking a supplement can be more beneficial. However, with that said, if you eat the diet, the study that did show eating fatty fish, I think it was 2 times a week, a serving, which would be a 3 to 4 ounce serving. It was either 2 or 3 times a week, did show some beneficial effect. But what I want to say more importantly is that before anybody takes a supplement, it's important to look at your base diet. I call it your base or your background diet, because no supplement is going to have an optimal effect or be able to do its job if you don't have the background diet in the proper homeostasis, if that makes sense. So if your background diet is all astray and you're just trying to take supplements because you don't want to decrease the sugar, you don't want to decrease decrease high glycemic index foods, or you have a hard time increasing fruits, whatever it is, fruits and vegetables, and you take a supplement, it's going to minimize the effects of that supplement. So it's really important to look at the background diet first and foremost, and secondary add supplements. But with that said, in the dosages that studies have looked at, a supplement is really primarily one of the only ways most people can get the amount of omega-3 fatty acids required to see a response.
Great. Thank you very much, Kristen, for that presentation. It was very informative. I learned quite a few new things myself, so that's really great.
Okay, well, thank you for joining, everybody.